Welcome to the pharmaphorum podcast. This is web editor Nicole Rowley, and today I have with me a fellow podcaster, Dr. Jay Anders, host of the Tell Me Where It Hurts podcast, and that it isn't capital IT if you were wondering, listeners. He's also Chief Medical Officer for Medicomp Systems. Now, Jay recognizes that healthcare organizations are facing the simultaneous pressures of demonstrating ROI on AI investments, addressing clinician burnout, and satisfying compliance requirements. And so today, we'll be discussing why he believes that the only way organizations can solve all three of those problems is by first solving data quality issues. Welcome, Jay.
Nicole, thank you for having me.
Now, as you probably know if you've listened to any of the pharmaphorum podcasts, Jay, my first question is not going to be on today's topic, but rather on yourself. I was wondering if you could tell listeners a little bit more about yourself and about the path that led you on this journey to doing what you do today.
Well, Nicole, I started out as a general internist in a very large multi-specialty group practice, moved into management in that practice. And in the early 2000s, our clinic decided that we needed to move into the electronic era for electronic health records. And back then, they aren't anything like they are now. It was kind of a read-only system to try to get rid of the paper. That led me to being a consultant with a company, became their chief medical officer. It's called Integrate. And 3 iterations with that, I went from Integrate to a company called Med 3000 to another company you might recall or might know, McKesson, in their business performance services division, and then wound up at Medicomp, all doing healthcare records, being kind of the voice of the physician, both in design as well as usability and portability, and looking at how data is exchanged and what data is exchanged. So that's kind of how I got started. I'm a general internist by training, but I'm now out of full-time practice, just being the CMO of Medicomp.
Thank you. So, springboarding off the portability of data and what type of data, amidst all the buzz about AI and health IT, one big concern continues to emerge: how to address the issue of poor quality clinical data. Despite the impressive capabilities of conversational AI and LLMs, the effective implementation of AI is compromised because of the abundance of flawed clinical information. So, Jay, I was wondering if you could tell listeners more about this data quality crisis, if you will, including how we got to this point and the financial and operational impacts of the current situation.
Let me roll back to before this actually was AI enabled, to the era of dictation. When physicians would dictate notes, they went off to a transcriptionist that would actually create the data that actually goes into the note. It was the responsibility of the clinician to make sure that whatever got transcribed was correct. That responsibility still exists today. However, with the onset of the ambient listening, like you mentioned, and LLMs doing all kinds of manipulation of that conversation to present whatever is going to go into the medical record, there has been kind of a lull in the physicians and clinicians that use these technologies as I could set it and forget it, meaning I'm going to have my conversation, the computer's going to take care of everything, and whatever it comes up with is going to be correct. Well, we're finding out that that is not the case. And it's not been the case where we're not having that human in the loop. The thing that AI has done, in my opinion, is accelerated that to light speed. So clinicians now need to really be careful about what they're reviewing, because not only for what they're creating, but in the interoperability world, what data they're receiving. So not only are they responsible for what they do, they're responsible for what data they're getting into. So some of the issues that have come up, I'll give you a couple examples. In meaningful use, there is a whole host of questions about tobacco use. Very common. Do you smoke? Do you not smoke? Well, in the electronic world, there is a big difference between never smoked and not smoking. So if you think about that for just a minute, never smoked, you don't have the risk of whatever tobacco is going to give to you as the human. If you said, I don't smoke, well, that could mean I stopped smoking this morning, but I'm not smoking now. It's a totally different concept. It's a totally different clinical concept when a clinician starts to assess risk or do counseling or do whatever is necessary to treat a patient. The other thing about some of these systems, and this has happened in the paper world as well, it just gets more accelerated in the electronic one, is misdiagnoses are put in, wrong diagnoses are put in. And I'll give you a couple of examples. One of my own family members recently went to her primary care physician. I got to read her note, and her note had glaring errors in it and something that would be misconstrued by someone who really didn't know this person. So going back to her, the primary care physician, saying, hey, this is not quite right, getting it corrected is very difficult. One of my colleagues has the diagnosis of liver cancer sitting in his medical record. It's not his liver cancer, it's his father's. To the point where people have asked him, well, you look pretty good. For somebody with liver cancer, it must have been a great treatment. How are you doing? Well, it's not his liver cancer, it's his father's. And he's tried ever so much to be trying to create, get the right medical record, get the right information in there. And it's very, very difficult to do. So when you think about bad data in equals bad data out. And now with interoperability, it goes everywhere.
That's quite an example you gave there with your colleague and his father's information on his own record there, Jay. Sort of extending out from my question, can we perhaps break down the financial implications of this to the system?
Well, there's a couple of big financial impacts. Let me talk about the patient first. And I'll use the same example I used. Now I have a diagnosis of liver cancer in my medical record that's not mine. What do you think an application for life insurance for a patient who has that diagnosis would be? Would it be successful or not? Probably not. Most life insurers will not insure somebody with an active diagnosis of liver cancer. That's a financial impact on them. And if they actually can get insurance, it's going to be at a markedly higher rate than they had before. And also going forward, that's a misdiagnosis that someone's going to have to decipher when that medical record is received downstream to another clinician. Oh, you have this, like I said, you have liver cancer. You look pretty good for liver cancer. Well, you don't have liver cancer. So the financial impact on a patient can be very personally great. You can get denied for things, you can get denied for jobs. It can be very impactful at a patient level. Let's roll back to an organization. So with bad data in an organization, you are also acting on things like projections of budgets. You're doing RAF scoring for the Medicare Advantage program, all of which is based on those diagnoses. And if those diagnoses aren't correct, your reimbursement predictions are going to be incorrect because someone down the road, most likely HHS, when they do cross-checking, is going to figure out, wait a minute, there's nothing in this medical record that supports that particular diagnosis. And that's kind of where we wind up with the impact, both on clinicians or patient care, organizations for actually predicting medical cost and trying to do the business of medicine, and absolutely the patient, because they're at risk because there is misinformation in their medical record that if they would wind up in an emergency room unconscious and not be able to answer questions, that clinician is going to believe what they have. So that's the problem with bad data.
Absolutely. So it's crystal clear that providers have to ensure clinical data is validated, cleaned, and optimized, in short, correct data before it even enters AI systems. So, Jay, in what ways can organizations leverage technology itself to solve the issues with problematic data challenges, such as bad mappings or duplicate items or inadequate codes, or, as you say, even incorrect data to start with?
Well, starting in data creation at the point of care, it is absolutely necessary for clinicians to be involved in creation and review of what's been created before it ever gets put in a medical record. Is this, at the best of my ability, correct? And we've been doing that for ages, even since we were writing handwritten notes. We ought to make sure what we're writing down is the right stuff. So moving forward with that, there are AI technologies out there that can be applied to existing data that will identify things. And this is one of the things that LLMs do very, very well. Is there anything in this medical record that supports this particular diagnosis? Let's do a cross check. So using my liver cancer example, Well, there's been no biopsies, there's no tissue, there's no pathology, there's no test that support that anywhere in the medical record. Use AI technologies to alert the clinician that this could be a problem, then have the clinician correct it. So going downstream from that point, there's something in there that says, wait a minute, there's nothing here that supports that. And you can do that clinical, I call it washing, ahead of actually presenting data to a clinician. I'm not saying remove things from a medical record, but I'm also just, you need to highlight them so the clinicians know there might be something amiss here with the information you've been given.
Thank you, Jay. So it comes back to clinician responsibility again, quite clearly. So if we think about originally the shift in the early 2000s, which scarily is about a quarter of a century ago now, given the shift in the early 2000s to EHRs, to electrifying, if you will, patient records, and given the issues that still exist with LLMs and AI and the advancement yet ongoing with AI, in your opinion, if we think to future horizons now, what's your projection for that horizon there in the future? And, or your key takeaway or takeaways for our listeners today when it comes to perhaps improving ROI on AI investments through solving what we've been discussing today, which are those very valid, very serious data quality issues.
Well, a couple of things. Right now, I'm reading a lot of folks writing about governance in AI in healthcare specifically, meaning what are the rules regarding LLM implementations, AI solutions, and things like that. And that's kind of at its infancy. HHS has done a fairly good job starting to outline some of those things, but governance is going to be the rules and regulations that we have to actually implement these new systems. One of the things I'm absolutely a soapbox for me is a human in the loop. Ultimately, the clinicians are responsible for what they are putting in a medical record. And I'm going to add to that now the patient, because now with patient portals and all these notes going out almost immediately to the patient for review, it's kind of up to the patient to say, wait a minute, you said this about me, and that's not true. So getting it corrected is a dual responsibility. The thing I was talking about with ambient listening is sometimes ambient listening just gets it flat wrong. And what I mean by that is another colleague in the note that they were provided got his gender changed 3 times in the same note, which was just mind boggling. And that was it. It was signed off. And there it is. It's a he, no, it's a she, no, it's a he, no, it's a she. So it's things like that that AI could screen so easily. Wait a minute, you said 2 different genders in the same note, which is it? And like I said, that's been a problem for a long time with people dictating notes and not reading notes and not being responsible for what's going in. But now the patients are getting those notes, and back in the old days they didn't, but now they do. So it's kind of a joint effort of the care team to figure out, hey, what's correct here, and if it's incorrect, to correct it.
I agree. An additional question for you, Jay, on this patient coming into the human in the loop concept. You mentioned the existence of patient portals. To what extent, given the difficulty, I believe it was your family member perhaps, who had issues correcting glaring errors in their note from the physician, to what extent will there need to be a change in the system in order to provide the agency to the patient to get the details corrected?
Well, they need to be provided that information. They don't know what's been said until they see it, obviously. The other thing that needs to be applied in the system is an easy way to correct it. And what I mean by correcting it, not just going forward, let's go back in the medical records and say, put a note on everything that's being passed that this has been checked and it's incorrect. You really can't go back and change medical records in the past. That's a big no-no. But you can certainly attach a note to one and said, this has been reviewed and this particular item or these particular items are incorrect and they need to be changed. And here's the correct answers that we got on this date. So there are systems out there that can do that right now that need to be applied as cross checks. Ultimately, it's a human in the loop. Humans need to read these things. They need not to blindly trust them because they aren't right all the time. And it's concerning to me that a lot of this was created to prevent physician burnout. But my opinion is it's going to create a different thing for physicians to have to do. It might be equally leading to burnout as what it was trying to correct. So now I've got this to read. I got to make sure that's okay. And now I'm responsible for it. So think about the cycling of this. So my biggest takeaway here is before data gets in, make sure it's correct. Cross check it before you say, that's it. My signature is on it. Off it goes. And if it is incorrect, there needs to be something in the loop that will inform people downstream that it is incorrect so that it doesn't get propagated without comment. And that's the issue right now. Things get processed down the road and there's no comment that it's ever been reviewed and it's not incorrect. Trying to get all that in the same loop. So that's my biggest takeaway. Make sure it's good when it goes in. Let's put some systems in place and use LLMs not to treat patients, but to actually sift through their medical records to make sure everything looks good. And if it doesn't look good, flag it and do something with it.
Absolutely. Simply put, clearly put, perhaps as simple as a digital post-it note. Thank you very much for your time today, Jay. It's been an absolute pleasure.
Nicole, thank you for having me.
And that concludes another episode of the pharmaphorum podcast. You can find more information about this episode, including a download link and information about previous installments at pharmaphorum.com/podcasts. The pharmaphorum podcast is also available on Apple Podcasts, Spotify, Overcast, Pocket Casts, Podbean, and pretty much wherever else you download your other podcasts from. Just search for pharmaphorum and follow and hit subscribe. Of course, don't forget to visit our website itself, where you can sign up for daily and weekly news and analysis bulletins. And do follow us on Blue Sky and LinkedIn at pharmaphorum. That's all for now. Thank you for listening.